So thank you. We had some good talks related to management of advanced bladder cancer. That is why my job has been made easy. So I will try to keep it crisp and to the point so that we can have a clear consensus. So starting with a case, a 65-year gentleman, hypertensive, TCC bladder, which was also involving the ureter. The patient was having clinically T3N1 disease. Patient received standard NSAT with GEMSIS 3 cycles, underwent nephrourectomy with bladder cuff excision, and this was in 2017. Patient had nodal and liver recurrence in 2021. Now what to do? Let's start with Dr. Amit. Dr. Amit, how would you proceed with this patient?
So since the metastasis is only at node and liver, we'll work up of the general condition of the patient. The performance status and the organ function of the patient has to be evaluated first, and thereafter we may go for the palliative intent therapy with chemotherapy with most likely gemcitabine cisplatin for patient.
Okay. Ma'am, would you like to rebiopsy this patient?
Yes, I would like to rebiopsy the patient before starting on the palliative therapy, because it's been 3 years post-treatment. And then, like Sir said, gemcitabine cisplatin can be rechallenged if all the factors of cisplatin eligibility are there.
Okay. So do you think this patient had nephrourectomy, kidney was removed? So it's likely to have lower GFR. So how would you proceed to take the GFR? Would you do just Cograft-Gault formula? Would like to do DTPA GFR in this patient?
So usually in our center we prefer DTPA.
Okay. Dr. Preeti, what's your comment?
Yes, I would also like to prefer go for DTPA GFR. In this case, the Crockford formula will not be accurate. So I would definitely like to go for DTPA GFR.
Okay. Especially in single kidney, if other kidney is also having somewhat borderline levels, we would be very concerned utilizing cisplatin, because that cisplatin can lead to toxicity in the single kidney, and that can be difficult for the patient. And so this is the point. How do you consider platinum eligibility? These are the standard criteria. Dr. Preeti, again, like requesting to highlight these criteria.
So platinum ineligibility, ECOG PS more than 2, low GFR, you have mentioned 30, but giving below 50 is also difficult. Cisplatin, neuropathy, heart failure, difficult to give cisplatin because of the fluid we have to give along with cisplatin.
Okay.
Yeah.
Dr. Amit, when you call a patient as not suitable for even carboplatin, when do you consider a patient? Because most of the time, most patients are carboplatin eligible. But in which scenario do you think the patient is also carboplatin ineligible? In which scenario do you think?
Surely, if there is a very low GFR along with other neuropathy, patient is having neuropathy, and these two are the most common thing, and along with organ dysfunction, if there is a heart failure like situation, in that case we may omit carboplatin also.
So, yes, ma'am.
Yeah, I think that is very subjective. Many a times we feel it's mostly based on the performance status and age that we decide that, okay, this patient may not tolerate chemo and we want to avoid chemotherapy. Otherwise, most of our patients get clearance, if it's more than 30 carboplatin, we can give.
Okay. And any other point to add in this list?
So baseline hematological parameters should also be evaluated before contemplating carboplatin. They're known to cause thrombocytopenia. So that may be sometimes complicating.
Yes. So I completely agree. Sometimes patients have been treated multiple times previously, and the patient might be having constantly lower platelet counts, which we commonly see in ovarian cancer, but not so common in this cancer, because here the patient would have received cisplatin, but not carboplatin. Usually the patient would have been fit for the same. So yes, completely agree with my panelists. So out of the various regimens available, GEMSIS definitely is the most common one. Dr. Preeti, have you utilized DDMVAC anytime in your?
Yes, we have used DDMVAC, but GEMSIS is definitely, it is easy to give, well tolerable, and the data is good in our setting.
Okay. So definitely DDMVAC lead to significant toxicities, and you should have sufficient beds to admit the patient, sufficient things to manage the same. Resources, yes, because the toxicities also will require management, and that will add cost to the treatment. So all these getting all these factors into our mind, we utilize GEMSIS mostly. Dr. Amit, do you agree?
Yeah, surely. So if it's a fit patient, young patient, still we'll go with DDMVAC. Otherwise, GEMSIS is the most easy to give.
Yes, thank you. So with this, we come to see the median PFS associated with these drugs. MVAC is around 9.5 months PFS and OS of around 15 months. With Gemsys, it is around 7.7 months, but OS is not much different, 14 months, and definitely much more higher hematological toxicities. So it seems that till now we can reach to this consensus. Patients who are eligible to receive cisplatin-based chemotherapy, the patient should receive the same. And this usually is Gemsys in our practice. If cisplatin ineligible, definitely we try to utilize carboplatin. But only rarely this patient may be not eligible even for carboplatin. So what are the situations where you would utilize first-line immunotherapy in a patient? Dr. Preeti, you can go ahead.
Yes. So the patients who are ineligible for any chemotherapy, whether any platinum, whether cisplatin or carboplatin, and if you feel that patient should receive any form of therapy, then yes, immunotherapy will be the option because it will be less toxic for the patient.
Okay.
Only in that case.
Only in that case. Anything to add, Dr.?
Surely. So it's a great rarely. So in last my patient, it's a 81-year-old gentleman with a cardiac failure. In that case, I'm not able to give any chemotherapy. So immunotherapy, he go on with pembrolizumab for 8 months.
Okay.
After that, he succumbed on that.
Okay. So pembro and atezo, as you just highlighted, these are the options which have the FDA label to be utilized in patients in the first line, irrespective of any PDL1. So these can be utilized. Let's see this patient. This patient, which I just started with the case, this patient had baseline, you can see, large liver mets, and after 4 cycles of gem carbo, these had significantly come down. Now, how to move ahead? The patient had recurrent thrombocytopenia. Ma'am, would you like to continue gem carbo based treatment, compromising the frequency, or you would like to utilize any other treatment in such scenario?
So this is after 3 cycles we have.
4 cycles gem
4
carbo,
cycles
scan
gem
was done. Yes.
So here if the patient's it's a grade 3 thrombocytopenia, it depends. Like if it's a grade 1, you can sometimes we have drugs like romiplastim to help us and then continue if we really want. But here 4 cycles are completed, I would consider putting this patient on a maintenance therapy, extrapolating the data from the Javelin 100, though it's not for recurrent. But we can put this patient on a maintenance avelumab to take care of even the thrombocytopenia.
Okay. Any difference or?
So I'd not be able to comment on this immunofront, but if that is the only site of persistent disease, then probably I would be tempted to offer SBRT as well.
Okay. So, but at this, as I had highlighted, the patient had multiple site of disease, though other site has also responded well, that has also come down. So we have liver site and one more site.
In that case, we should continue with systemic treatment.
Systemic treatment. Okay. Okay. So Dr. Preeti, this patient received 4 cycles of gem carbo. As per the data, would can you utilize avelumab here only, or would you like to wait for giving till 6 cycles? What is
No, we can start avelumab now.
We can
that,
start.
yes.
So in fact, this is an important point which has just been highlighted. After the trial had 4 to 6 cycles, that is why we can utilize avelumab maintenance even after 4 cycles, and this is this can be done. Slides. So yes, which I wanted to highlight here. So Dr. Sandeep Bairwa, sir, since you are here, I would like to take your comment. Would you like to do PD-L1 testing at any time point in urothelial bladder cancer? Any scenario where you would like to consider doing PD-L1 testing? Anywhere in the time point of treatment of urothelial cancer patient?
This question, but I will not do a PD-L1 testing.
Yes. So, Dr.
Except when we are planning atezolizumab in the first line.
Setting. Yes. So, in the first line setting, if you are planning a treatment with immunotherapy first line, then definitely it would be prudent to test PD-L1.
I usually do PD-L1 for most of the patients because it's not a very costly test, and it's easier to counsel or convince the patient to take immunotherapy sometimes when the PD-L1 is especially high, like considering financial toxicity of it.
Okay. Okay. So if we see the data from this Javelin Bladder 100, it's very clear that the patients with overall population did equally well as PD-L1 population. Yes, I completely agree. We always see that PD-L1 population patients tend to do somewhat better than PD-L1 negative population. So though we do not, this do not helps in deciding whether to give or not to give, but we can just prognosticate and give the response rates to the patient if we are having PDL1. And this, I completely agree. PDL1 is not usually required, but it can be done for academic purposes and counseling the patient. So this is the slide which showed that after Javelin, in the patient's Javelin 100 trial, what treatment was given after utilization of avelumab maintenance. So to see, this is what I wanted to highlight. I will highlight here. Subsequent drug therapy in patients who were avelumab arm, FGFR inhibitor could be given to around 3% of the patient, and 40% patients could receive other form of treatment. PDL1 inhibitor in 6.3%. So it's actually immuno after immuno in 6.3% of the patient. In supportive care alone arm, if you see, PDL1 inhibitor were given to around 44% of the patient. Dr. Amit, do you think this is a strength or weakness of this study? 43.7% patient could receive immunotherapy in the second line treatment on supportive care alone arm. So whether it is a strength of the study or
surely it's not the strength, it's a weakness, I'll say, because if you have made a patient on supportive care and thereafter on further progression you are giving a treatment, it's a tough call because the patient might have received the treatment upfront.
So actually what is happening here, I would like to, you can see it here, around 30% patient could not receive any form of treatment on the supportive care alone. So I think that is very small there. So what I would like to read out, patients who were on supportive care alone arm, 30% patient could not receive any form of treatment. So that is the main problem. That is why we want to utilize any other treatment or maintenance treatment. Dr. Preeti would like to comment.
Yes, I want to comment. So even after, like we had 44% patients on immunotherapy after progression, even though there is overall survival advantage with avelumab maintenance, that shows that utilization early is better than utilizing late.
Yes, so that is important, because I always tend to utilize this point. Urothelial bladder cancer has somewhat tendency like a small cell cancer. They respond very well to platinum, but very frequently they relapse also very fast. So that is the main problem. We all have very good experience with small cell. We see the patient responding very well to treatment, and then in 2 months recurring back just after stopping the treatment. So avelumab maintenance has clearly shown survival benefit, and this adds. And yes, around 50% patient could receive immunotherapy in the next line after progression. So yes, this is the things. Anyone having experience of utilizing FGFR inhibitors and where it is indicated, ma'am, would like to comment? FGFR inhibitor?
I don't have any experience of using it. But yes, now that we have data that if there is a FGFR mutation present, then it can be used even in second line or subsequent line of treatments.
Okay. Dr. Amit, exactly in which FGFR mutations or fusions would you like to utilize?
So it's FGFR 2, 3, 4, which is most commonly.
Yes.
Otherwise, now FGFR are also available.
Yes. So definitely FGFR 2 and 3 fusions, and some specific FGFR3 mutations. These are the two specific points where idafitinib has been approved, and this can be utilized in this scenario. And idafitinib compassionate access is available with us. So that is why we have some patients on idafitinib compassionate access program supported from Janssen.
So you do FGFR receptor testing, that whatever, how do you do this FGF testing? NGS based testing.
Those are in the kit, in the label. If you do RT-PCR specific for FGFR, that is also fine. But that test is not very easily available. And we try to do NGS in most of the patients wherever we find. Because this treatment is available on compassionate access, that is free of cost. That is why we try to find ways and means to do NGS in our patients, even at the baseline. When we had got a biopsy, at that time only in our practice we try to send, because if you wait for doing a testing after the patient has progressed on platinum or immunotherapy, then I think you have already missed the boat, because you don't have so much time left that patient will utilize. And also utilizing compassionate access requires a lot of paperwork, importing of the drug, that takes some time. So utilizing more time for doing biopsy and then sending the testing, it becomes difficult. Dr. Amit, your suggestions, your comments on this?
I truly agree. So in metastatic patient, if affordable, I'm also doing NGS upfront in all the patients, though the report I'm using later on for the later lines. And if FGFR is positive, surely to contact the companies and to do all these works. I have used it in one of the patient of gallbladder. Somehow I've got this FGFR mutation and started erdafitinib on that patient, but not for a bladder.
There is a phase 2 trial of combining erdafitinib or enfortumab vedotin with immunotherapy. And even if we try to extrapolate to erdafitinib also, if patient is FGFR2/3 mutant, we try to utilize erdafitinib and also try to utilize immunotherapy. Though I agree, full dose is not easily accessible. Only 3% patients can utilize immunotherapy, but we have a large number of patients who are utilized on alternate doses of immunotherapy. I would like not to comment exactly on the same, but yes, a significant number of our patients receive altered doses of immunotherapy, as we all know from our practice. Dr. Dodal, where would like to incorporate SBRT, whether in a patient where there is a single site of disease, patient responded very well, but other sites have completely disappeared, one site is remaining, whether you would like to consolidate at that time, or since patients were having multiple sites of metastasis at the baseline, you would like to avoid SBRT. What is your suggestion?
So the role of SBRT in urothelial cancer is not very well established. We do see the role of SBRT in CL lung, prostate, and also in certain breast cancer patients. But as of now, there is no convincing data to suggest. However, we often get tempted to offer it. So in this particular patient who had multiple metastases after finishing the systemic treatment, if there is an oligopersistent disease, so probably that will be the only situation, oligopersistent disease, then I might offer it after explaining that even after that, the disease can progress elsewhere or even at the persistent disease site. But if there is an oligoprogression, of course, I am not going to offer it, because in any case, that disease biology is very bad. So maintaining maintenance treatment or supportive care will be a better option.
Okay. So, Dr. Preeti, in such a case where SBRT has been given to oligopersistent disease, what is your take on systemic treatment? Whether you would like to continue some form of systemic treatment or would like to hold on?
No, I would like to continue some form of systemic treatment, because the disease is systemic. It is not localized disease, and the patient is going to relapse if you don't go ahead with the systemic treatment.
Okay. And any comment on the lymphotech guidelines which are now available for utilization of radiation in patients who are on immunotherapy or others?
Not very much that.
Okay. So now there is some data, and that has also been from our center, that which have shown that if we are giving us too much dose to lymphocytes, that means wherever we are giving radiation, if too much of lymphocyte, there is lymphocytopenia, that is going to affect the benefit of the immunotherapy. So we always try to request our radiation oncologists to limit doses of radiation to the marrow sites, so that wherever it is feasible, we can consider.
So in any case, we have our guidelines to keep the marrow dose within limit even when we are doing SBRT. And I think if they're being followed properly, it should not be a problem.
Yes. In SBRT, I completely agree.
So other than this, to answer your previous question, where should I use SBRT? Probably spine mets not going inside spinal canal, or maybe another side, another area.
Yes. Otherwise, you'll never able to give a good amount of dose.
Yes.
Ma'am, you wanted to comment?
I just wanted to ask the panelists, so if there is a palliative RT, means SBRT is going to be a short session, but if there is planned for a palliative RT for any reason, do you continue immunotherapy or do you hold it during that time, or do you continue it after completion of RT?
We want to ask whether during the session where the patient is going palliative RT. So actually, we do hold for some point of time. Like palliative RT is not very long duration. I think maybe like sometimes it's a single fraction, sometimes 10 days only. So we may like 3-4 days delay, we may do it.
Yeah, usually I don't think we make a long
it doesn't matter much actually.
Yeah. So since it is, if we are giving
in a few patients, depending on the volume of radiation and what are the area of radiation and what is the intended impact of that radiation on your ongoing systemic treatment. So that might impact this decision. So if I am treating a distal bony site where active marrow is not involved, and there is no significant surrounding organ which can also get compromised during the course of immunotherapy or ongoing immunotherapy, I don't mind continuing palliative radiation or SBRT along with the systemic treatment.
So yes, I completely agree with the same. So these are the updated data for the erdafitinib phase 2 data, around PFS of around 5.5 months and OS of 11.3 months in the second and third line. Similarly, enfortumab seems to be a very good drug, yet not available either on compassionate basis or on commercial basis. But the study for phase 4 is going to come by next year to our institute, and we would like to see the utilization of enfortumab as well in our patients. So that will be a learning experience for all of us. Apart from this, the sacituzumab govitecan, this has been much discussed in TNBC setting, and there is a response rate, decent response rate of around 30% in difficult to treat patients who have already progressed on platinum-based treatment and immunotherapy. Around 1/3 patients responding to the same. So these are the all options. And so just to summarize here, if patient has received immunotherapy already, in the patient has progressed, we can utilize pembrolizumab, which has the maximum phase 3, largest phase 3 data. Apart from this, the options include Nivo plus Nivo and avelumab. Avelumab is based on phase 2 data. Upon disease progression, if the FGFR mutation is present, you can utilize erdafitinib. There is no head-to-head comparison to utilize erdafitinib versus enfortumab if both are available, but we don't have access to enfortumab. That is why we try to utilize erdafitinib. Sacituzumab govitecan is also not available on compassionate basis. We have imported sacituzumab for few of our patients for both TNBC and bladder cancer, but it's a costly treatment, and that is why the utilization is minimal. In patients where such mutation is not present, the option of erdafitinib is not there. Otherwise, we can utilize other treatments. Any role of any other chemotherapy in such patients, because even immunotherapy will not be affordable by large number of patients. Any comment on that?
Surely. So if the patient progresses, the most patients are going to receive single agent chemotherapy. There are single agent paclitaxel most commonly we are using in this profession.
No. If patient is having grade 3 neuropathy because of previous cisplatin, any other drug would like to utilize?
So the other options are single agent gemcitabine. If there is a long gap, we can consider the gemcitabine, paclitaxel. Otherwise, Relvin can also be, I think so, used in this profession.
When it is actually vinflunine, which is not available to us. So, ma'am, anything to add?
Vinflunine has data, but it is not available.
Yes.
I think, yeah, gemcitabine, like for one patient, we sort of modified the drugs used in MVAC and you gave modified doses, and he's on almost like third line. Even after taxane, he progressed. So we have gone back and using doxorubicin, so MVAC, methotrexate, vinblastine, and these two drugs we are using in a modified dose along with cisplatin.
No. So one more drug which can be utilized, which based on small phase 2 data, is pemetrexed. Apart from this, so these are the options. Mostly we try to utilize paclitaxel, as Dr. Amit has already highlighted. So there is the option of these drugs, and weekly paclitaxel is the preferred protocol in our settings. So, but if it is not feasible due to logistic issue, we tend to utilize 3 weeks. Any other points or comments by anyone? Please. Yeah, so this is an important point. Anybody would like to take it? Gemcitabine plus paclitaxel.
So like when patients are not cisplatin, platinum eligible, and we want to still, means chemotherapy only has to be given because of financial issue, then gemcitabine paclitaxel can be used. However, I have not used it for any of my patients.
Dr. Petri?
Also remains an option for some patients, and here we used gem as day 1 and day 8 regimen as, and pacli can be given weekly or 3 weekly.
Okay. The only problem with gem pacli combination is high amount of ILD. So drug induced pneumonitis is common in this combination, because gemcitabine also causes pneumonitis, and pacli is well known to cause pneumonitis. So we need to be aware of that. If you are utilizing gem pacli, it is perfectly fine. It has good response rate of around 40 to 45% actually, but due to the dreaded toxicity of, because both have overlapping toxicity of pneumonitis, we try to utilize, but it might not be always utilizable.
In platinum ineligible patients, like gem pacli versus single agent gem, like patients, no, then single agent gem can also be considered.
Yes, in selected young fit patients with high disease burden, I think gem pacli can be utilized. Otherwise, single agent gem.
In that case, gems may also be, then becomes the first option then.
Yeah, gem alone. Thank you. If any other comments?
I think this was a very well conducted panel discussion. And if there are no other questions from the house, probably we can wrap it up.
Thank you. Thank you.
Thank you for the wonderful discussion.